go into it, so this is what it looks like when you open it up, right? So you're gonna put in your name, and then join lesson. You're gonna go through it, and then at the end will be that quiz. But notice that your name disappears from that, right? So to get your name, just bump out your little profile, and your name will be up there, okay? And then screenshot that with your quiz results at the end of that nearpod, okay? You do not need to get 100%. It's just kind of gauging where you're at pre-lecture, right? So you've gone through that pre-lecture content. It's going to quiz you on the stuff that you just went over in that to see where you're at, and then we'll kind of fill in the gap through lecture and applying that to clinical. Cool? Okay. All right. Any questions before we get started? There was an announcement that was posted about missing videos in the Nearpod. So there was a bunch of communicable disorders that were in there, and I think there was like 3 videos that weren't loading anymore. Michelle went through this morning and found some videos to replace those. So a lot of those communicable disorders are just kind of a overview of disorders that you might see. One that we're going to specifically focus on as it relates to vaccines is chickenpox. All of those other ones are just kind of good to know, but we're not going to go in depth with those, and we're not going to test on those. We're going to stick to the chickenpox. And then we'll go over pertussis when we get to respiratory, and then we'll go over like conjunctivitis and like pink eye stuff when we get to week 4, when we go over like eyes and neuro and stuff like that. Cool? Okay.
Are we able to log into this Nearpod, or is this just?
So my presentation is in Gamma, but I uploaded your lecture slides in the module.
Yeah, it's in there.
Right? Okay.
I like your ChatGPT.
Isn't she great? It's Gamma. So if you haven't used Gamma, it's really good for putting together presentations with an AI component. Right? They make things look very, very nice. There were some things that I had to adjust because they had like an extra finger, or like the chart was weird. So I like you can mess with it, and you can tell it like make this more realistic or whatever, or as you're doing the slides, you can tell it to make it more visual. So it just kind of puts all the information on it, and then there's like no pictures, and if you tell it to make it more visual, it adds like all of that stuff to it. So something that I realized this last go around. Okay. So, the agenda for today, we're going to go over the lecture. We're going to end lecture with going over pediatric dosage calc. Okay, it's not anything new. You've gone over it in foundations. It's just kind of a review of like weight-based calculations. We're going to go over using body surface area calculations, 24-hour fluid calculations. So there might be a few things that are new, but for the most part, it should be slight review. Okay. I'm not going to go over the syringe pump today. Today's kind of content heavy. I'm going to move going over the syringe pump next week, and because you'll be using that syringe pump in clinical the following week. Okay. Have any of you worked with a syringe pump already? Have you seen one? Yeah. Okay. So we use it a lot in peds because the dosages are so specific that we can't just hang a secondary bag, right? So a lot of the meds come up in a syringe, and we put it on the syringe pump, and that's their secondary, right? So instead of having like the secondary bag, we have a secondary syringe that we'll use, and it has its own pump. So you program it on the channel just the same way. But we'll go over that more. Next week, I'll show you how to set it up, the supplies that you're going to need, and stuff like that. Okay, and then we'll finish the day with going over a developmental case study. Okay, So I'm going to throw all of the content at you, and then we're going to apply it today in that case study. If we don't get through the whole thing by the end of today, you can continue to work on it at home. I will post the answers for you, and then next week, if you have questions, we can kind of go over it and review it. Okay. This week's stuff, you will start in your clinical rotations next week. We're going to go over well child days, so we're going to go through their head-to-toe assessment.
I know the schedule's set, at least for Mondays, it's at 9. Is it from 9 to like what?
So if you look on the schedule, it's all on there. So the first day is 9 to 6:30?
Yeah.
9 to 6:30, and then the rest of the days are 9 to 4:30. So the first day is just a little bit longer than the last 3 days.
What day?
Okay. So your clinical rotation. So there's four sim days.
Mine's at 7 to 1.
Yeah, mine says no 7 to 4. The first day.
Oh, but you come in earlier.
So there are two groups that'll run on the same day. One group will come in at 9, and one group will come in at 7. One group will come in at 9.
Oh.
That first day though is longer than the other 3 days. So it's either 7 to 4:30 or 9 to 6:30, I believe, that first day. And then like 2:30 to 4:30 are the other days. Cool. But on that the schedule in the experiential course, it has your the full day layout. Okay. So yes, so we'll take everything that we've gone over today. That will be applied to next week's clinical. So starting off pretty basic, pretty healthy. So it's your well child day. You're going to do a head to toe assessment. You're going to do a developmental assessment. You're going to do a lot of parent teaching. You're going to give vaccine injections. You're going to use the vaccine information sheets. You guys know what those are? So you know, like when you go and get the flu and they hand you the sheet that says, here's what the flu vaccine is, why we're giving it. Those are available to you, so you'll be able to use those and guide your education. There's also, how many of you have kids? So when you take them in for the well child day, like you have that, fill out that form, right? Like my child does this, or my child isn't doing this. That kind of helps gauge their developmental assessment. And so you'll have those pieces to kind of guide your simulation as well. And then there's a sheet from the American Academy of Pediatrics that goes over like their what they should be doing now as far as developmental stuff, injury prevention education, like safety teaching, all of those sorts of things. So you're gonna have all sorts of resources to help guide your simulation. Okay? You're gonna be working in pairs of 2. So in your group, you're going to do 2 simulations. You're going to have either an infant or a toddler, and either a school age or adolescent. So one younger kid, one older kid, and you're going to do that full head-to-toe assessment. Okay, a full intake assessment, because what you're going to get in report is this child is new to the clinic and we don't know anything about them. You have to gather the information and build their chart. Okay. So you're going to go through and ask them all of the questions, do all of their assessments, all of that intake piece, and you're going to chart that, okay, and build their chart. Your partner, who is not the nurse for the first simulation, is going to have an observer role, and it is scripted out. Okay, so for each of the simulations, there is a script that I have put together for you, so that whoever is the nurse doing their assessment, the observer is going to have that script and is going to give the answers based on what you're finding in your simulation. Okay, so I know this is all new, and a lot of your simulations are kind of just you go in and you have to kind of fight your way through it, right? You're learning, but it's not very scripted out for you, right? These are very scripted out. Okay, so it should flow very, very well. Cool. So again, I know that there's a lot of information in this chapter, or in this module, but we have set it up so that we have different ways that we're going to use that information, so that it becomes easier to flow as we move through the rest of the stuff. Cool? Okay. Okay, so going over some learning objectives for today. So we're going to go over setting classroom expectations. So what I expect from you, what you expect from me, to make this a very efficient time together. And we're going to go over principles of atraumatic care. We're going to talk about what that is and how we provide that to the pediatric patient. We're going to go over family-centered care. It is very different in peds than it is in adults, right? In adults, you're mostly focused on the patient, whereas in peds, we focus on the whole family, okay? We're gonna go over health assessment, we're gonna go over health supervision, so what that looks like, going over your head to toe assessment, what pieces you should be looking for, that health supervision, so, you know, when they come in for their well-child visits, what do those components look like? What are we really doing in that well-child visit to know that they're on track for where they should be, okay? We're going to go over pharmacokinetics in children. So how drugs move through the body. Is it different in kids than it is in adults?
Oh, yeah.
Yes, absolutely. How it moves through the body, yes. But what it does in the body, does that change?
Yeah. No?
No. So pharmacodynamics is how the drug works, right? It works the same, but how it moves through the body is different. A lot of it is due, especially in our younger kids, their immature systems, especially like that blood-brain barrier, it allows things to move through that in an adult patient it wouldn't, right? Or the kidneys also don't filter as well at first, right? Because they're not fully functioning, so they don't have the ability to concentrate urine, so everything just kind of flows out. So that is different. So we'll go over that. And then we'll go over dosage calc and med administration practices in kids. Cool. So as far as setting classroom expectations, I expect respectful listening. So if I'm up here talking, side conversations need to not exist. If you have a question, please raise your hand, interrupt me, whatever. I am all about taking questions and answering your questions as we go, okay? Minimizing those side conversations, active participation. That is huge. So when we break out into small groups, which we'll do at the end of the day when we work on that case study, making sure that you're participating in that activity and that you're not distracted doing something else, right? I wanna make sure that you're getting everything from the activity while we're together, versus just kind of doing other stuff and not really kind of participating, okay? And then preparedness and punctuality, just be here on time, right? It's disruptive to everyone else if you're late, and coming in and getting settled during lecture, okay? I know that there are times where it is unavoided, so as long as it's not a habitual thing, fine, okay? But just try to be here on time and ready. Cool? All right, so let's talk about peds nursing a little bit first. How many of you want to go into peds nursing? A couple of you, okay. What are your perceptions of peds nursing? What scares you about peds nursing?
Hurting kids.
Hurting kids? Okay, in what way?
I just don't know. They don't know that you're helping them, so having to like stick an IV in them or Foley or stuff like that, they don't understand or comprehend.
Right, especially our younger kids, or even sometimes our older kids who are not cognitively able to understand that, right? Because they've got some intellectual abilities that aren't quote unquote the norm, right?
I feel like it's kind of scary, especially nowadays where things are a little bit less strict and you're not just, the patient's not just the infant, it's also their parents.
Okay.
So it might not be just an angry infant, it could be an angry parent.
Okay.
But it's their way or the highway, and then I just don't know how I would go
Okay.
about that situation.
Okay. What else?
I think for me, it's more like, I guess what people say, like, oh, you could be like, a kid could be like fine 1 second and like the next second it's like a whole different story. So just like how different it is from, like the adult can warn you in a way with like your body versus the child.
Okay.
It's
In
like-
what way? Because you're very right.
Well, Well, like Professor Moore was saying, like vital signs, like your adult patient would tell you, like, hey, there's something going on, like look into it. Versus I haven't been like the peds, right? But like the peds, like
Yes.
they can look like fun and like
Yeah.
you know.
Absolutely. So we will see that, like, in the adult population, we get this trend, right?
Yeah.
Where you can see that they're over time slowly decompensating, right? With kids, they're really good at this compensatory mechanism that they have built into their body. So they can look real great, and then like that, they are not. And that has happened to me. I had a kid who had pertussis, and I went in, did my assessment, looked great for the situation that they were there for, right? No immediate distress, nothing I needed to do right at the moment. So I did what every day nurse does and went and got breakfast, right? While I was in the cafeteria, they called a code overhead. Everyone pays attention to when a code is called, right, to see where it's at. So I was listening, and they called it in the pediatric department, and I was like, oh, well, that sucks. I was like, one of my teammates is not doing so great right now. And then they called the room number, and it was my patient's room number. It was that kid that I had just checked on. He was perfectly fine when I left, and then went into a coughing bout while I had left, and was not fine. And when I got back, they had already started CPR. Right? I actually left a mess in the cafeteria because I went to like set my plate down, and I missed the counter, and it like fell all over the floor as I ran back. Right? So yes, absolutely, kids can change in an instant. Right? So you have to pay attention to even the finest detail of them not doing so good. Right? When it comes to the family, a lot of it is like, you know, that the perception of, oh, the parents are angry, right? Like, I don't think I can deal with the parents. But that piece of it is so small. The percentage of parents who are angry with you is so small. Most of the time, they're so grateful that you're taking care of their kid because they can no longer do it at home, and they are so exhausted and they needed help, right? So more often than not, we're gonna find
It's a misconception.
it is a misconception that dealing with the parents is the most awful piece of pediatrics. It's not. And a lot of the time, like, the parents are so great and they're so grateful, and they still participate in care, right? Now we do have ones who aren't as participatory, and we do have issues, but it is so far and few between that it's not that big of a deal. It's not a huge piece of what we do, right? And my specialty is hematology oncology, so I truly see kids at their worst, right? Last year we lost 2 of our patients. It was hard, right? But the connections that you make with those families last forever, right? Especially when they ask you to attend the funerals, right, and be there. Other times we see kids, you know, they come in. Most of the time when they come in, it's like during respiratory season, right? They've got some upper respiratory infection. They're young. Their systems can't handle it, so they need help, right? They need some fluids. They need some oxygen. We see them. They get better. They go home. We never see them again, right? So you kind of see kind of both sides of that. Right? So peds is a lot. There's a lot of things that go into it. But a lot of those perceptions are misconceptions, right? Peds is really, really rewarding if you really get into it, okay? So that's really kind of what makes peds a specialty, right? We're looking at like the family-centered care and how that changes your focus from just the patient that you have, right? Because in adults, a lot of time you're just focusing on that patient. You're not really looking at the rest of the family dynamics that they have. Sometimes, yes, depending on their situation, but not a lot of the time. Whereas with kids, especially in kids who have a chronic disorder and also have siblings, where do you think the parents' attention focuses? On the child with a chronic condition, right? And so there's less attention for those who don't have that chronic condition. So then you see a lot of like behavioral outbursts and stuff like that in those other children. So we have a child life specialist, and we'll go over that kind of as we move through. But it's so great, and these are not people who are just pulled in off the street and are like, go play with the kids. like they have degrees in childhood development and things like that to make them a very special person and a very important part of our team, to make sure that not only our patients are being taken care of, but their family and their sibling. So that kind of leads us into like the next piece of where do we see peds patients? So we see them in the hospital, right? We talked about that already. Where else are you going to see a peds patient? At the school, doctor's office, right? Daycare, okay. Home health, right? Infusion clinics, right? A lot of things, okay? Do all of those areas give us an opportunity to lay eyes on the kid and say, hey, your child's developing well, or hey, there's an issue?
Yes.
Yeah, especially those well child visits, right? Because in general, kids are fairly healthy, right? They don't really have a lot of comorbidities like your adult patients do when we get older, right? Things start adding in. You turn 40 and find out that your knee is completely like disintegrating and have to go in for steroid injections on Friday. I mean, you know, it's fine. Side story. Had an MRI on Friday because I've been having a lot of issues with my knee, and I went in and I saw my ortho yesterday, and I was like, so how bad is it? And she's like, well, let's just start at the top and work our way through. I have a miscellaneous category because of how many things are wrong. Yeah, so I have a steroid injection I'm gonna get on Friday. And then I found out about these hyaluronic acid injections that are like a derivative from a piece of chicken that they'll inject. All sorts of things. I have a meniscal tear. It's great. Yeah, so those comorbidities, right? We don't often see those in our peds patients. They're usually fairly healthy, right? And if they do have something going on, it's kind of very specific to that condition and not a lot of extra conditions on top of that, right? So we have all of those areas that we see them in to really kind of make sure that we're staying on top of their growth and development and saying something when we realize that, hey, maybe this kid's not doing what they should be doing, right? And catching that and getting those early interventions, because the earlier we intervene, what's gonna happen? The better the outcome, absolutely, right? As soon as we can intervene, we identify those early, get those services on there. Do they need PT? Do they need OT? Do they need speech therapy? What do they need? Do they need a combination of that? And what's gonna help them, right? So that we can tackle that, okay? When it comes down to the clinical judgment model, so you've heard us talk about that, right? The clinical judgment model and what that looks like, right? The nursing process, what was it before? ADPI, right? It's different now, right? We've got new fancy terms for essentially the same thing, right? So you're going to do your assessment, you're gonna recognize cues, right? So you're gonna see that. And we'll kind of use those pieces as we move through. So recognizing cues, what does that mean?
Recognizing something that could mean something else, like if they're having trouble breathing, that could be like a respiratory issue.
Absolutely.
They might need oxygen.
Yeah, so you're looking at the data that you collected, and is it normal or is it abnormal? And then kind of moving through that process, right? So we've recognized that, hey, this reading isn't right, or these retractions in this kid are concerning, so what does that mean for us, right? Is it a respiratory thing, or, is it normal for them, okay? And how does that guide our practice, okay? Is it different in peds than it is in adults? It is not. We're still doing our assessment. We're still gathering that data, recognizing those cues, analyzing those cues, creating our hypotheses, what are we gonna do for them, right? And then intervene, and then evaluate, right? Still the same process. The things that we do for them are gonna look a little different, right? Because retractions in a kid could just mean they need a little bit more oxygen, right? Or they might need like an albuterol inhaler or something like that, right? So look at your patient, what do we have, okay? So looking at principles of atraumatic care, when you hear the term atraumatic care, what does it mean to you? Not traumatic care, okay. Okay. Break that down a little bit. What does that mean?
Like not causing stress to the patient.
Okay. Not causing stress.
Psychologically.
Okay. Looking at their psych component of that. Okay. Who else is back here?
Actual sickness, some type of illness.
Okay.
It's where you like, kind of like help, like build the trust, like look at my stethoscope.
Yes.
And-
Yes. Right. Reducing those stressors. Play, and we'll get to play in a little bit. But play is a huge component of what we do in the hospital, right? But when it comes to taking care of the kids, we really want their stay to be as less traumatic as possible, right? So you talked about like holding them down, traumatizing them. They don't know what we're doing to them, right? Our younger kiddos, absolutely, they have no idea, right? They have no idea why there's 5 nurses holding them down trying to get an IV in, right? This is where child life comes in. They are a huge component of this atraumatic care, right? But the overall goal is to minimize that physical stress, prevent separation, right? We don't want to separate them from their parent if we can help it, right? So when we do like invasive procedures, we have a treatment room that we'll go to keep their room a safe space, right? So if we're gonna do an IV insertion or like a Foley insertion or anything that's gonna cause like physical harm or anything like that to them, not that it, like that physical, I don't wanna say physical harm because that's not really what it is, like, but that invasive procedure, like an IV or a Foley insertion, it's not comfortable, right? It's not really causing them harm, but it's a part of what we need to do to help them, right? And it's very stressful. So we want to keep them together, right? Because their parent can be a very calming component of that piece, okay? Now, I always ask the parent if they want to come along, because you do have some parents who will vasovagal, and then you have 2 patients instead of 1, right? And remember, you're a peds nurse, and that person on the floor is a little bit bigger than what you take care of, right? But your patient comes first, and the fact that they fell, like, that comes second, okay? But you don't want that. So I always ask them, do you want to come along? And I do.
More dramatic for the kids.
Yes, sometimes it is, yes. And I've had times where like this, big bulky dad is like, yeah, I'll go in, and then he gets white as the sheet and he's like leaning against the wall, and I'm like, can you sit down in that chair, please? Right? And I do that. I vasovagal, and I told my ortho, I was like, I will definitely pass out on you on Friday, so be ready for that. And then family-centered care ties into that too, right? We don't want to separate them from their family if we can help it, okay? However, we can't have a lot of extra visitors or siblings stay overnight, right? It's rare that we'll allow the siblings to stay overnight, but we encourage them to come through during the day if they can. So if our patient's not on isolation or restricted from visitors in any way, we definitely encourage them to come in. Especially our older patients where they're in a developmental stage where their friends are a huge part of who they are in that developmental process, right? But we're looking at that family-centered care. How can we incorporate the family into what we're doing, right? We still encourage them to help with the child's ADLs. So we want them, changing their diaper, feeding them, helping them to the bathroom, right? If they need help, we definitely want to encourage them to ask for help, right? Especially if we've had a kid who's got like a spinal fusion, or they've had like the pectus excavatum, or those chest surgeries where they've either got like the pigeon chest or they've got the concave chest, where we essentially go in and they break the sternum, right? Those kids don't move around very easy with those, or the spinal fusion. And so sometimes the parents don't feel super comfortable doing that, but they still try, and then they come in and they're like, hey, can you help at least get like this process, right? So we still encourage them to do that, because guess who's gonna be helping them when they go home? They are, right? So we still want them there, right, and involved in that care, okay? And that gives them a sense of control, right? Because when they come in, we kind of take over everything, right? Or it seems like we take over everything, but we really don't. We take over the medical care that they're there for. So I've had times where parents will come in and they just like sit on the couch and they're on their phone and their child is screaming in the crib and they're not doing anything about it. And I'm like, listen, this is how it is. You came in, your child needs medical care, that's why I'm here. If you are going to be here, you need to participate in their care. If you are not, then you don't need to be here, right? And we've had parents escorted out who are just hanging out and not doing anything because they're, that's kind of that gray area, they're neglecting their child, right? When their child is screaming and crying in there and they're not holding them, they're not feeding them, they're not changing them, you don't need to be here, right? And even starting with, why aren't you helping, right? You can start there, okay? But sometimes we have had to get to the point where we're like, if you're not gonna do this, like we've talked about this, you can go, like you don't need to be here, right? But for the most part, what we're looking at is still promoting their sense of control, right? What can they still control about their stay and what's going on, so they don't lose that sense of that piece, okay? Therapeutic communication is a huge part of atraumatic care, right? How can you use therapeutic communication with our PEDS patients to make sure that you're getting to where you need to be with this atraumatic care?
Speaking to that, we have their developmental stage.
Okay.
It's gonna be different, 5-year-old versus 10-year-old.
Okay, so like the words you're using, your tone, okay, absolutely. All right. What about how you approach them to begin with?
Calm, friendly,
Okay,
empathetic.
okay, calm, friendly, empathetic.
Connecting with them in some way first before.
How, especially for our younger kids, how can we do that? Because what are they afraid of? Us, right? Absolutely. Go to the caregiver first. Don't ignore the child and start talking to the caregiver first, right? Because what's that gonna do to the child? What are they gonna see?
See that you're
That you're a safe person, right? Hey, my parents talking to them, that must mean it's okay for me to engage with them, right? And so you're starting to build that trust instead of just walking in and being like, hi, I'm Eric, I'm gonna be your nurse today, right? They kind of freak you out a little bit. Right? But getting down on their level too, like getting down eye level. Hi, I'm Eric, I'm gonna be your nurse today, right? You think that's gonna help kind of bridge that therapeutic communication?
Yeah.
Absolutely, right? I mean, I stand well over the level of their bed and it freaks them out. And so one of the things that I do, I raise the bed up as high as it goes, and all of the kids absolutely love it because it's the first time it's ever happened. And they're like, they look at their parents and they're like, what's happening? And I'm like, I'm a little bit taller than everybody else. Like, you're coming up to me. Like, I've got a degenerating knee. Like, I can't get down at your level. Right? So I bring you up to mine. Okay? And then the childhood education, or the child education. So looking at it in a way that's developmentally appropriate for them, right? So the terms and the words that we use are not going to be the same for a toddler that we use for an adolescent, right? Because can an adolescent understand more of what's going on, right? Why they're there, right? However, we still have to keep in mind that the average reading level of the US population is what? Like 5th to 8th grade, right? So you're not going to use some of those medical terms that we know and would apply to things, right? We're going to still use terms that they're going to understand. Okay. But when you're, when you're putting in an IV in a young school age child, you might say that, we're going to put this tube in your arm and it's going to put, fluid through there, right, or something like that. Versus in adolescent, you're like, yeah, we're going to put it in an IV. All right, we're gonna give you some IV fluids, we're gonna hydrate you, right? Whereas with that younger kid, you're gonna say, this water that's going into the bag, it's gonna make it so that you're not so thirsty, right? it's gonna do the work for you, so you're not having to drink because you can't right now, right? So switching up how you're talking and what you're telling them is gonna be huge. Right? Distraction is huge when we're looking at atraumatic care, right? And again, it's based on their developmental level, yeah? So how we distract a toddler is not gonna be the same way we distract an adolescent, right? So what things can we use for like our younger kids versus our older kids?
Toys.
Okay, toys.
Ask what interests them and then relate it to it.
Yeah, what do they like, right? Can we blow bubbles? Can we like use those like noisemakers, right? For younger kids, we got a lot of, actually for all of our kids, we kind of have a lot of options, right? But what we use is going to be different. So younger kids are going to be a lot of the toys, things that make noise, things that they can shake, throw a tablet in front of them and distract them from what's going on, right? So if we're having to put in an IV, can you block their view of where you're working with the tablet or the iPad with their favorite show? Absolutely, right? And so that distracts them from what's going on, okay? Our older kids, when I do IVs, I do almost all of my IVs via an ultrasound guided method. And so I show them what's on the screen. Like they can see the screen. I walk them through, like I show them their difference between like their vein and their artery, and how like when I squish a vein, it stays squished, but when I squish an artery, like it pulsates, right? And I'm like, that's not what I want. And so we're looking for like a nice big, big dot on the screen. And then I walk them through the whole thing. I'm like, do you see that nice bright dot that's going through there? I was like, that's the tip of the IV. And that's distracting them so they're not seeing what's going on, right? Cool. We've got music, Pandora, if you have like Pandora or Spotify. For our younger kids, I always put on like a baby lullaby channel and play that music so that there's just some nice calming music in the room, okay? Making sure that you have one voice, right? So one person on your team is doing all of the talking of what's going on so that not everyone's talking over each other and it doesn't seem so chaotic, right? Because how many nurses do you think it takes to put in an IV in a younger kid? Like 4 to 5, right? You've got a nurse on their legs, you've got a nurse on either arm, you've got one nurse who's actually doing the IV, right? So there's a lot in there. If you're all talking, do you think that's gonna freak them out? Yeah, because they don't know where to focus their attention, right? There's so many people talking and they're like here, there, over there, right? It's like an ADH brain going off, right? And it's just too much for them, and that freaks them out, right? So they're gonna scream, they're gonna cry, and it's gonna be more traumatic than what we're trying to make it already, right?
I like the video of the doctor giving vaccines who's like tapping the kid and all the different
Yes,
places.
tapping all the different places, and then gives it, and it's like the kid had no idea. Yeah, because he's all over the place, and the kid's expecting a poke in all of those different places, and then when it actually happens, it's like he was so distracted that it didn't matter, right? I also really like the one of the girl who like is freaking out and she's like, ah! She's just scared of the needle, right? The whole time, and then when it's done, she's like, oh, that wasn't so bad, but she's like hyperventilating already. So lots of distraction methods, right? So just kind of as you're moving through those developmental chapters, just take a look at like some of these pieces, right? How are we going to do that based on their age? Okay. So our child life specialists, right? We kind of mentioned them already. So one of the things that they do is therapeutic play. So therapeutic play is a method that they will use to help them express their emotions, right? So if they've gone through some sort of like traumatic event, especially our younger kids, they don't have the vocabulary to put together what happened, right? But can they show you using dolls? Absolutely. Can they draw it? Might not be great, but you're gonna get a better picture that way than them trying to explain it because they don't have the words to tell you what happened, right? So our child life therapist or specialist is really good about using that therapeutic play. They also do medical education. So we'll use them if we're gonna put down an NG tube or anything like that. They have like dummies or like stuffed animals that they will take in there and they will show the child this is what's gonna happen, right? And they will allow the child to play with some of the equipment that we might use. So as long as it's not gonna hurt them to kind of play and manipulate, let them do it, right? This is what we're gonna use. Give them one of those disposable stethoscopes, right? I can't use those anyway. They hurt my ears, so they're useless to me. So I just give them to the kid. I'm like, here, play. But it helps lower that anxiety in them, right? Because they're seeing that equipment beforehand, right? So they're not scared when we pull it out of the package for the first time and be like, what's that? Where's that gonna go, right? So they'll work with them on that medical education. They're there for emotional support. So not only are we gonna see them in inpatient, right, when they get admitted to the hospital, but they're gonna see them in the ER. They do have a child life specialist in the ER. They will help, again, with that family-centered care, especially if they're coming in a not so great situation, right? If they're coming in and that situation is maybe gonna result in like the death of a child, they are there and they will help with bereavement support, okay? They will take, if they bring the other siblings in, they will take the siblings elsewhere and they will go play with them while the medical team is doing what they need to do in that situation, right? So there's a lot of different aspects that we'll see them in what they do to help us, but they are a huge and valuable part of our team. If they are not available, who becomes the child life specialist? You do, right? Get real good with playing with your kid, right? A lot of it is just play with your kid. It's gonna be great. Okay. Cool. Any questions? Okay. Advocacy is another huge piece of what they do. So as they're in there and dealing with the children and seeing what their needs are, one of the members of our child life team is a school teacher. And so she will advocate for what the child needs as far as not falling behind in school, right? Or what things might need to be in place for them after discharge. So especially if they're going to be out for a while or they're going to have restrictions when they go back to school, they will make sure that child, they're kind of that kind of liaison between the school and the family and making sure that they're getting what they need when they get discharged. Cool. And then the medical education and the procedure prep are kind of the same thing. They do that medical play. They will take them on tours if they can, so they will show them the different areas that they might be in and what that's going to look like as they kind of move through if they're having like a procedure. So they're, we'll see them in pre-op. So they are there. So if they're going to go in for a surgery or some sort of procedure where they're going to go under anesthesia, the child life specialist will be there. They'll prep and be with the child during that time. And then they will be there in post-op when the child is working up too, to make sure that they have things that they need when they're recovering too. Cool? Okay, so looking at the family-centered care when it comes to the peds population, information is huge, right? What do you need to know or do about the information that you're giving the family during the time that they're with you?
I would say like not sugarcoat.
Okay, don't sugarcoat it, right?
Like be clear with them.
Be clear with them. Make sure it's unbiased and be honest, right? If you don't know something, it's okay to say, you know what, I don't know right now. If they ask you a question and are they gonna be okay? The biggest one, are they gonna be okay? I don't know. We're gonna do everything we can though to make sure that we get the best outcome, right? When they come in for especially like respiratory, and we'll talk more about that next week, but a lot of the time they do get worse before they get better, right? Sometimes they've stayed home too long and they get better with us, but sometimes they will get worse with us before they get better, right? Because there's a peak of their illness, so we'll see that they do get worse. So yeah, sometimes I don't know what it's gonna look like, but we're gonna do everything we can to make sure that we get the best outcome, right? Assistance is huge. So assisting them with their needs while they're there, supporting them and their family. Okay, so we kind of already talked about that already. So like, what support do they need, right? When they come in, ask them, like, especially if they're gonna go home with like follow-up appointments. Do they have the transportation that they have? For us here in Phoenix, we only have, well, now 4 Peace hospitals, right? We've got PCH on the West Valley, Thunderbird in the West Valley, PCH, Maine, and then Desert Gardens in the East Valley, right? We get a lot of kids from Yuma, or like,
Where do you work?
I work at Thunderbird. Like Flagstaff, somewhere like way out there, way rural, way away from the children's hospitals, right? So if they're being diagnosed with, like, say, a seizure disorder and they need to be followed by neuro, but there's not peds in Yuma or Flag or Kingman, where are they gonna go, right? How are they gonna get back to us to follow up with that care, right? So looking at assistance, what assistance do they need? Okay, and that kind of goes along with collaboration, right? So when their child comes in, we still want them to be a part of care. So we want them to collaborate with us. We're gonna tell them, this is what your child is doing right now. I don't have a monitor out where I'm at, so I don't see everything. But I need you to tell me if you're uneasy about something. Or if you see these certain signs and symptoms, I need you to tell me. Right? That is being a part of a collaborative team, right? You want to work with the family and not against the family, right? Or if they have special wishes, or things that they want to do while they're there, can we incorporate those things? Or are they so whacked out that you just can't? Like when you walk into a oncology family cleaning their room with a bottle of vodka. Is that an okay thing? No. How about scrambling eggs on a hot plate in their room?
Please tell me you've seen that.
We have. Same family. She was very concerned about how many people would be exposed to her son's food tray before it got to the room. So she insisted on making his breakfast and had a hot plate in his room. And when we discovered that and told her she couldn't have that, she went outside and plugged it in outside and scrambled the eggs outside and then brought them in. Because that's so much cleaner than just having our cafeteria deliver them, right? Or yes, walking into her, like pouring vodka on things and rubbing it down because our hospital-based cleaners weren't cleaning well enough. They weren't disinfecting well enough. Those are things that they cannot do. We see some crazy things, okay? Like I see some crazy things in adults, but I've seen some real crazy things in peds. Okay? So, goals of education. What are we looking at when we provide education to them? What outcomes do we want? To know that they've understood it. Making sure they have all of their answers, or questions answered, right? Absolutely, right? So, how many times have you been in a room with a patient and the physician walks in and explains everything, and then they walk out and the patient's like, so what did they just say? That would have been a great question for them before they walked away, right? Like, what procedure am I having? What is it going to entail? Yeah, I'm pretty sure they just went over that. So you're going to step out and you're going to bring them back, right? Because they have to go over that stuff, right? There are some things that we can go over, but when it comes to the procedure, like especially a surgery, the surgeon has to go over that. And if they have any questions related to the surgery, the surgeon or surgical team has to answer that. You cannot, because you're not going to be there during the procedure, right? You might know what it entails, but it's kind of out of your scope to go over that. The surgeon needs to do that, right? So the first one there is improving health literacy, right? So how many times does a patient come in and they truly understand why they're there or what their medical diagnosis is, or even why they're taking a medication, right? I can't tell you how many times. So I did work in adults before I switched to peds. I would be asking them their medical history, right? And you're asking, do you have high blood pressure? Do you have diabetes? Do you have all of these conditions, right? And they say no. And you're like, okay, let's move on to your current medications. And they give you 3 medications for blood pressure. Okay, hold up. You just gave me 3 medications for blood pressure, but when I asked you if you had high blood pressure, you said no. And they're like, yeah, no, I don't have high blood pressure. Then why are you taking these meds? Well, I did have high blood pressure. No, you have high blood pressure. It's being controlled with your meds. So things aren't being explained to them in a way that they fully understand and remember, right? Just because you're on these meds doesn't mean you no longer have high blood pressure, right? Yeah, your readings are great, they're where they're supposed to be, but without that medication, you still have high blood pressure, right? So improving that health literacy is huge, right? Making sure they truly understand why it is they're there, what's going on, and what we're doing for them, right? And what that means going home, okay? Encouraging communication. So we have those whiteboards in the room, right? And one of the sections that's on there is, do you have questions for your health team, right? And so when they first come in and you're doing that admission, there's a lot going on, right? Are they gonna remember everything? No, right? When I was in the hospital last year for a week, I couldn't remember that I actually had a CT done in the ER. And so when the doc came in and was talking about it, I was like, I don't know what you're talking about. I didn't have that. And because I was so out of it with sepsis, it was crazy. I have a lot going on. It's fine. I promise I hope I'm gonna get through all of our time together.
Sure you don't need to sit down.
I know, right? I'm feeling it's twinging today. Hopefully after Friday I'll be fine though. But a piece on that board is, do you have questions, right? And so we have a dry erase marker for them. So at any time they have a question, write it on the board, right? And the next time I come in, we'll go over that, right? That way you don't have to try to remember, right? Or leave a piece of paper with them or something. Encourage that communication with their healthcare team. If you have questions that come up about stuff that we didn't go over, or you remember something, let's go over that, right? Encourage that communication. Don't just kind of keep that to yourself. Healthy lifestyles. This is huge, right? Again, the earlier we start educating about healthy lifestyles, the better the outcome, right? So one of the things that we'll touch on a little bit later is specifically healthy lifestyles, right? And there's an increase in childhood obesity, which is then leading to what? Diabetes, right? Specifically type 2, right? When we think of childhood diabetes, we think of type 1. That is not related to obesity, right? Obesity is directly related to type 2, or type 2 is directly related to obesity, however you want to look at that, right? But because there's an increase in one, there's an increase in the other, okay? Again, involvement in care, making sure that they're engaged in their decision-making, their care plan, right? Ask them, are there certain cultural practices that we need to be aware of? Is there, like a clergy that you want to talk to? Things like that, right? Encourage them to be a part of their care plan, because not every patient is the same, right? a lot of the stuff that we're gonna do for them might look the same, but if they've got different cultural practices or different like views on healthcare, that's gonna look very different in guiding our care plan, right? So we wanna make sure that they're engaged in that. And if we can incorporate those things, as long as they don't interfere with what we're doing, can we do them? Yeah, absolutely, why not, right? Just talk to the physician, right? Collaborate with the physician, be like, hey, you know, they take these supplements, is it okay that we incorporate these things, right? Or, you know, they want aromatherapy, is it okay if they bring in their own? Because we don't necessarily have that for them, right? If it's okay and it doesn't interfere with what we're doing, sure, why not, right? It's gonna get you a better outcome, it's gonna get you better patient satisfaction scores, okay? Leading to improved compliance, right? So if we're going over all of these things, right, we're improving their health literacy, we're encouraging their communication, involving them in their care, is it going to increase their compliance? Absolutely, right? We want to go over all of this stuff with them, especially when we get to like our adolescent patients who, you know, again, looking at their developmental level, they're when they're in their stage of identity versus role confusion, right? Have any of you taken a look at that? Can you tell me what that means?
What is it?
Identity versus role confusion?
Like the,
Kid gets,
I guess they're trying to figure themselves out.
It's Erickson's.
And it's like their stages of development and understanding, but specifically, yeah, understanding themselves,
Like
but
you know,
also.
like you get your own identity, like you trying to, your parents have raised you to be doing certain things and you on your own, you trying to figure out what you want to do for yourself.
Yes, right? So this is where they're in a transition stage where prior to this, their focus has kind of been on their family unit, right? But now they're moving into this identity versus role confusion where they're trying to figure out who they are in the world, and they're transitioning away from their family unit and more to a peer group, because peers are more important to them now than their family, right? As a part of who they are and a part of their identity, okay? So when you're looking at a peer group, you typically share characteristics within that group, right? Of a similar kind of background, similar style, right? But now one of you has a chronic disorder. Are they always forthcoming with that? Why not?
Embarrassing sometimes.
It could be embarrassing, right? They're worried about how their peers are gonna perceive them, right? What did you say?
I said at that age, they're worried about fitting in.
Fitting in, absolutely. So now if they have this chronic disorder and they have to check their blood sugar and they have to give themselves insulin, are they going to be less compliant? Potentially, especially if they don't want their friends to know, right? But if we can go over all of these other things with them about how important their disease process is and their compliance with that and what can happen if they're not compliant with that, and giving them the autonomy to take on ownership of their disease process, is that going to improve compliance? Hopefully, right? So that we don't end up in a situation where they went out to a party and maybe there were some drinks going around and they passed out and everyone's thinking, oh, they're just drunk, but really they're in what? Yeah, a hypoglycemic state, right? Okay, where they just need some sugar, right? It's not because they passed out because of the alcohol, it's because their sugar dropped too low, right? Because they didn't know what their disease process can do when they take in alcohol, right? Cool. Go ahead and take a 10-minute break and then we'll come back.